So fluid resuscitation, appropriate fluid resuscitation, the first 24 to 48 hours or 45 hours with the Parkland formula only, that is 2 to 4 ml per kg per body weight into the percentage total body surface area burned. For the first burn sustained, half in the first 5 hours, half in the subsequent 16 hours. Substance and fluid already given, use warm isotonic balanced crystalline solution, that is Hartmann solutions we have to give, that is Ringal lactate. Okay, whatever fluid we get, we transfuse the first we transfuse half of the fluid in the first 5 hours and next half in the subsequent 16 hours. Colloid rescue we have to give, that is 4.5% human albumin. Target an urine output of around 0.5 to 1 ml per kg per hour. Check peripheral pulses, check serum lactate level, check balance deficit and hematocrit. So this is the initial phase of the life, or initial 24 hours we have to do this much, because the main area of concern is hypovolemia, and by giving so much of fluids we have to maintain the intravascular volume. This is our first goal in the first 24 hours. Coming to the thermoregulation, as the patient is hyperthermic, and when the temperature inside our body will increase, the patient now in the catabolic state and hypermetabolic state, so we have to decrease the heat, minimize heat loss, prevent a temperature more than 30 because it leads to multi-organ failure. Debulking dressing should be done, as now the skin is totally burned, and as there is no barrier, the patient now going on losing heat to the environment very easily. Administer antipyretics such as paracetamols. Apply ice on the non-burned areas. Infusion of cold IV fluids if required. Irrigate bladder and stomach with the cold fluid, either through rice tube or through a Foley's catheter. You have to irrigate the bladder with the cold saline. Consider invasive procedures such as intravascular heat exchange catheters or extracorporeal circuits. Heat exchanger catheters are now available. You can directly put the invasive heat exchanger catheter intravascularly, and through this it is generally costly, but it is we can achieve the temperature very easily and very fast. So they generally, this is not only for therapeutic, this is also can be done for prevention also. By simply putting an intravascular heat exchanger catheter, you can know the core body temperature, and also you will monitor and you will change the body temperature very fast, but these are high cost. Coming to the nutrition part, whenever a ICU management comes, you have to write everything: fluid resuscitation, monitoring, nutrition, everything, ventilation. So in this way, if you write in the exam, you will get good marks, because heading matters. Whenever it's a question of 5 marks, give 5 headings: temperature monitoring or management of temperature, management of nutrition, management of oxygenations, management of urine output, management of fluids. Burn patient, considerations, this, and management, these are the headings. So when we give answer or when we write in exam paper like this, you will get good marks. So basal metabolic rate increases significantly, that is twice, the basal metabolic rate would be twice in the 40% burn. So start enteral feeding immediately after the injury. If the patient doesn't have any GI perforation or GI ulcers, you can start enteral feeding. Consider post-pyloric feeding if there will be strong gastric ulcer or gastric status is present, to reduce the risk of aspirations. Parenteral nutrition is rarely required. Most of the patients can be survived with enteral nutrition. Parenteral nutrition is very less required in the burn patient, but be cautious. There are higher chances of infections, overfeeding syndromes, or refeeding syndromes, or erratic blood gas control will be there. Assess calorie needs with indirect calorimetry or formula. We have discussed nutrition in critical care. Just go through it.